Thank you, Karen, for the introduction, and thank you, Maria, Karen, and all Scleral Society for this opportunity. And thank you, Donald, for this collaboration. It's an incredible honor to share the stage with you. So, Don Ezekiel and I will discuss fenestrated scleral lenses, a topic that we studied and reviewed in an article just published in Optometry Vision Science. But before talking about fenestrated scleral lenses, I would like to clarify the terminology. Different terminology are available in scleral lens practice when describing a fenestrated scleral lens, which may be confusing. So a ventilated scleral lens refers to a lens which allows fresh tears to the cornea, mainly through fenestration or channels. Also, a lens that does not align properly with the underlying sclera may enable tear exchange and therefore may be considered a ventilated scleral lens. A sealed scleral lens has two conflicting meanings. This terminology is used to indicate a scleral lens without ventilation included in the lens. Clinically, a sealed scleral lens is a lens with an optimal relation with the underlying ocular surface and without any intention of tear exchange. So for clarification, in this presentation, the term fenestrated scleral lens refers to a lens with one or more fenestrations, and a sealed scleral lens indicates a lens without any fenestration. Donald?
The early lenses were made of glass and later of PMMA. These materials are impervious to oxygen, which is very important, but as you'll see in a moment, it's only one part of the equation for it to maintain a healthy cornea. Do we click to the next one or next? Sorry. Yep. Norman Beer on your right and Joseph Dallas on your left were really the pioneers of early scleral lenses. Dallas in I think mid-40s worked out how to take an impression of an eye, take a model of an eye, to create a contact lens which conformed to the actual shape of the eye. But these are all seal lenses. Is this the next one? This is a Dallas early lens with a large fenestration located in the limbus. There's a nice story of how Dallas worked out how. I was lucky enough to work with Dallas, so he told me a lot of things which I thought were very interesting and very historical. In our little paper that Daddi and I put together, recently published, there's this explanation or description of how Dallas worked that out. Basically, he made a mistake, but we all make mistakes, and I think the important thing is to stand back and look at it and say, well, where do I go from here? And that's what Dallas did, and we had to evolve to the fenestration lens. Yes, please, next. This is just another pictures of Dallas's lens, nice large fenestration located in the limbal area, and he got very good results. And very interesting, Dallas and Joseph Dallas and Norman Beer actually wrote papers and lectured on fenestration, the benefit of fenestrating a scleral lens. And basically, just the next slide. Basically, the change from entirely from a seal lens to an entirely non-suction lens. And interestingly, they suggested that chemical factors of pH as carbon concentration increased. These are the problems with a seal lens. The benefits of the fenestrator are not limited to the oxygen transmission. There's a break in suction, the replacement of tears, dispersal of CO2, preservation of osmolarity, and replaced artificial solution in the seal lens by normal lacrimal flow. So in 1947-48, Dallas and Beer stated that oxygen not only is the most important factor, but is more to the healthy, to maintain a healthy cornea, of the health of the cornea. Yes, please, next. Ken Barton Brown wrote this report. When I did my optometry course in Western Australia at the university, and Ken Barton Brown was an ophthalmologist who actually lectured us in pathology. He had just recently returned from London, where he worked, and learned how to fit scleral lens from Joseph Dallas. And he actually, in his lectures, continued to say how wonderful the lens was, and he could help people see who couldn't see before. I guess that helped introduce me into scleral, well, that did introduce me to scleral lenses. He actually, as you can see the notes on the bottom, the disadvantage of the lens was that it needed to be precise and it required time, and this was the main disadvantage of a fenestrated lens. He associated the veil with chemical suffocation caused by pressure on the conjunctival vessels, lack of oxygen to the cornea, and accumulation of carbon dioxide. So not just oxygen to the cornea, other factors were important too. Next. So with the introduction of gas permeable materials, the availability of this lens is now available around worldwide, and it's called the modern scleral lens, but it's sealed. So we're almost going back to the original lens, which was a sealed PMMA glass PMMA to fenestrated PMMA, glass PMMA, and now with the advent of the gas permeable materials, we have the modern scleral lens, which is sealed. Next, thank you. And these three gentlemen are really, I believe, responsible for the introduction of the modern scleral lens. Perry Rosenthal in America, Ken Pullen in the UK, and Reed Spitzer in Holland and throughout Europe. Thank you. Next, please. Now, the advantage of the sealed modern lens, and it's very easy, it's relatively easy to fit. We get great results for our patients who until now have not had the option of this life-changing lens. You know, I spent so many years doing workshops and giving papers, encouraging practitioners to fit a scleral lens because it's the only lens or any lens that will help people to see well. And I had very limited success. But with the modern scleral lens, which is relatively easy to fit, we now have this wonderful lens available to patients worldwide. Thank you. Next, thank you. But all's not perfect. But there are complications that can or do occur with a sealed scleral lens. Thank you. Next. Can we be? And the question is, can we do better? One thing Dallas always said to me: it doesn't matter how well you do something, how good you make it, what a good result you get for your patients, you can always do better. Thank you. Next. So the question is a sealed lens a healthy option for a cornea? Concerns are reported. Next, thank you. So adequate oxygen supply of the cornea is one important factor. Circulation of the cornea to remove the waste is important, but there are other factors involved. And that little picture on the bottom is a fenestrated lens. You can see the little bubble down at the limbus. Unlike a sealed lens, where a bubble is is important not to have included in the lens. With a fenestrated lens, a bubble is important. Next. So these are some of the, just a small snapshot of the problems that can occur and do occur sometimes with a sealed lens. Hypoxia, as we know, the epithelium receives most of its oxygen for normal metabolism from the atmospheric oxygen that is on the tear layer. Next. And Joe Shovlin looked at the endothelial blebs that occur shortly after contact lens is fitted, creating hypoxic stress. Is this good for this healthy for the cornea? Thank you. Next. Barry Island. Can we quantify the fogging of a scleral lens? The fogging of a scleral lens is unique to a sealed lens. You don't find that, you won't find that with a fenestrated lens. Next. Leukocytes with midday fogging in the post-lens tear film, and leukocytes present in the post-tear film. Leukocytes are part of the defense mechanism for bacterial infection. Is this healthy? Next. Possible risk for acanthamoeba due to the fluid reservoir and mineral tear exchange. I don't know if we've ever had a acanthamoeba infection, but this is all possible. Next. And we must get the fitting with the seal lens really quite perfect, so that it's sealed to prevent the formation of an air bubble. Is the seal one of the potential causes of increased intraocular pressure? There's quite a few papers now talking about the intraocular pressure being increased and raised with the use of a seal lens. Don't find this problem with a fenestrated lens. Thank you. Next. Lens suction. I think this is one of the very important things. Suction is created as a result of prolonged contact between the lens and the globe. It's enhanced by factors such as swelling of the conjunctiva and forces exerted by the lids with blinking. Next, please. Again, intraocular pressure variation associated with the wear of scleral lenses of different diameters. It's happening with a seal lens and with a suction. I think there's always a likelihood that the intraocular pressure will be increased. Next. The exchange from a seal lens is less than of oxygen is less than 2%. This is a referred comment by Poe. So we may get oxygen, only 2%, we may get more. But do we get rid of the debris from behind the lens? Thank you. Next. And this excellent book by Daddi, I don't know, I can't say enough complimentary things for Daddi. She really is very, very good. And this is a must read and known reference book. But it talks about issues and complications that you get with a sealed lens. You don't find these complications with a fenestrated lens. So maybe there is a healthier option. Next.
So, how fenestrated scleral lenses may resolve these issues? First of all, a fenestrated scleral lens does not necessitate to be filled with a solution before its application on the eye, so the lens needs only to be wet with a wetting solution as done with corneal lenses before its application. This may allow avoiding several issues related to the fluid reservoir and the subatmospheric pressure under the lens, such midday fogging, lens suction, and hypoxia. The application of C-scale lenses may be challenging. C-scale lenses should be overfilled until the solution appears convex over the lens. The eyelids should be opened wide and held tightly because they may cause lens concentration, creating air bubble formation upon application. And if the lens decenters on the plunger of fingers, it's necessary to reposition the lens to keep it overfilled with a solution, avoiding air bubble formation. The non-requirement of the solution in fenestrated scleral lenses, the patient does not need to have their head facing downward for lens application, facilitating lens application, especially in elderly patients and the pediatric patient, without the use of any device. In some cases, scleral lenses removal may be challenging as well, especially when they are fitted tight. And a non-adequate lens removal may provoke severe complication. A fenestrated lens is a non-suction lens, just as Don stated before. So lens removal is immediate and does not necessitate to use a suction cup. Including a fenestration scleral lens may reduce the lens pressure on the conjunctiva and eliminate the subatmospheric pressure, limiting the accumulation of debris under the lens. The holes included in the lens may maintain a normal osmolarity and may allow a tear renewal that flushes debris from behind the lens. And blinking results in a pumping action with a constant exchange of tears, allowing debris removal from behind the lens. And also, when fitting fenestrated scleral lens, the fitting requires low central clearance. And this low central clearance will thin any debris layer, resulting in a better visual acuity. The atmospheric pressure from outside the lens is greater than the pressure under the lens, resulting in a closed negative pressure system developing a suction force. So lens suction, we also call it lens adhesion, may cause discomfort, ocular health alteration, and an increase in IOP and reduced wearing time also. And it's essential to manage this problem because it may trigger a toxic metabolic reaction and severe complications such as edema, inflammation, and infections. The introduction of one or more holes in the lens reduces subatmospheric pressure under the lens, releasing lens suction and managing all these issues. In some cases, thin scleral lens may not be stable on the eye. Switching to a fenestrated large diameter scleral lens, just because it's a large diameter lens, may solve this issue. Also, the limited pulse fluid reservoir may allow the lens to be more stable on the eye. Conjunctival pressure and congestion may be caused by several factors, including lens exercising excessive pressure on the conjunctiva and suction. A fenestration eliminates lens suction again, and this will relieve compression on the eye. The reason, indeed, why Dallas accidentally introduced a fenestration was to relieve an area where the lens was causing compression on the eye. However, it's important to state that a fenestrated lens will not avoid compression if the lens is fitted tight or impinging on the conjunctival tissue. When limbal redness is caused by hypoxia, a fenestrated scleral lens increases the oxygen supply to the cornea, alleviating limbal redness. Also, the large limbal clearance needed when fitting fenestrated scleral lens alleviates limbal redness. Corneal swelling may be a response to hypoxic stress, increased IOP, functional condition of the endothelium, lens suction, and variation of the osmolarity. The introduction of fenestration scleral lens may potentially reduce corneal edema because of the more influx of oxygen and discharge of carbon dioxide and the decrease of lens suction, keeping normal osmolarity. Microcysts may appear in both corneal and limbal areas. The etiology of microcysts when wearing scleral lenses is hypoxia, lens mechanical stress, and tight fitting lenses. Suction and high IOP also may cause microcysts. As for limbal redness, hypoxia may be managed switching to fenestrated scleral lens. Additionally, fenestrated scleral lens are characterized by large limbal wall and the formation of a nerve bubble in the limbal area, which alleviate lens mechanical stress on the limbus. Similar to microcysts, neurovascularization may be caused by hypoxia, mechanical stress, tight fits, and suction. For the same reason mentioned before, a fenestrated scleral lens alleviates these complications. Different studies examined IOP changing during scleral lens wear, showing contradictory results. However, the potential cause for increasing IOP has been associated with suction force beneath the lens. A fenestrated scleral lens relieves this suction and pressure on the ocular surface, potentially avoiding alteration in IOP, especially in susceptible patients. The main disadvantages of lens fitting, well, it's mainly one, is lens fitting. The lens fitting must be precise, and this will take practitioner to take more time to have an optimal fit. There are different methods, Donald.
Yep. This is the method I used going back in a long time. In the days that I was fitting scleral lenses, well, the early days, we didn't have lasers that gave us quadrant-specific toric back surfaces, toric scleral surfaces. We had spherical surfaces. And the fitting methods I use, and this is a method that still can be used today, will be demonstrated on this little video. One thing that's interesting to note on the video, when the layers are old, but if you notice the technician there holding a rod, not a button of a material, but a rod. When they sent me the initial materials, I thought I'm sure Perry and Lou Major from Polymer Technology thought this was, sending me material just to keep me quiet, and they didn't even cut them up. They just sent a rod. But that's part of interesting historically. So this is, if you look at the method of fitting, this gives you an overview of how in the old days we've improved on it since then, but this will give you an oversight of how we fitted the lens and how we modify the lens to fit the patient. Next, thanks. Yeah.
The scleral lens is the only lens option for patients who must wear a rigid contact lens but cannot tolerate a corneal lens, and for those pathological cases where a rigid, stable lens is necessary. In the past, scleral lenses were made of glass and PMMA. These lenses are time-consuming and difficult for the practitioner to fit and for the patient to adapt to. As a consequence, the scleral lens has become a lens that has been generally overlooked as an optical aid that is readily available for the patient, when it is often the only optical aid that could be used to give effective optimal vision. The development of the gas-permeable materials and the application of these materials for the scleral lens has resulted in the development of a simplified fitting procedure for the practitioner and a comfortable and readily adaptable lens for the patient. The advantages that scleral lenses offer over other lenses are well documented. Ocular conditions best suited are advanced keratoconus, particularly those with a decentered cone, high irregular cornea as a result of trauma, corneal grafts that have very marked irregular astigmatism, numerous pathological eyes, corneas which are disrupted, distorted or dry due to lid deformities may be protected with scleral lenses. For ptosis or palsy, a bar can be formed on the front surface to hold lids open. Patients with a lens handling problem when extended wear would be inappropriate. As gas-permeable materials are heat sensitive, the molding of gas-permeable scleral lenses is difficult. All gas-permeable scleral lenses fitted and depicted in this program were lathe-turned from a button of material from the Boston 2, Boston 4, and the Boston Equilens supplied by Polymer Technology Corporation. The gas-permeable scleral material comes in the form of a blank or rod ready to be turned on a lathe. The lens consists of an optical portion and a scleral portion, and the fitting procedure is carried out in separate stages for each. The lens back optic details are obtained by using the Flom lens technique, the fenestrated lens for optical measurement, as described by Norman Beer. The Flom lens is a lens of defined optic radius and optic diameter with a small 1 mm edge flange and a fenestration. By placing the Flom lens on the eye, it is possible to establish the ideal lens-eye relationship for the corneal limbal part of the scleral lens. The ideal fit is one with an even corneal clearance, no corneal touch, and with a small arc-shaped air bubble at the limbus. Using the optimum Flom lens fit, an over-refraction is taken and the resultant power is calculated. With a keratoconic eye, however, the technique for using the Flom lens is different. The initial fitting Flom lens will have a marked central area of corneal touch, depending on the degree of the cone. This is ignored at this stage. It must have a well-formed bubble at the limbus. When the lens is received from the laboratory, it will be necessary to modify the lens back optic radius to eliminate the contact of the cornea on the back surface of the lens. This is achieved by observing the amount of central lens touch and then grinding up that area using a diamond-coated tool. The grinding tool used must have a steeper lens radius than the back optic radius of the lens, as established from the Flom lens. It is recommended that a curve 0.75 mm steeper than the back optic radius be ground to the diameter of the area of central touch, as noted when the lens has been placed in the eye. When the lens is now placed back onto the eye, the area of corneal touch will be seen to be reduced. Repeat the grinding using progressively steeper tools by 0.75 mm until corneal touch is eliminated and an alignment of the cornea to the lens back surface is obtained. It is important that an air bubble remains at the limbus at all times. The effect of grinding the back surface adds minus power to the final lens. It is recommended to allow an extra +3 diopters to the lens power ordered when fitting a keratoconic eye to allow for the power change caused by the central lens grinding. The scleral fit is established with the aid of a scleral fitting set. A recommended set would consist of 3 lenses with radii of 13.5, 13.75, and 14 millimeters, and an overall diameter of 24 millimeters. The lenses have a steep central radius to ensure total corneal clearance, so that the scleral fit only can be evaluated. The optimum scleral fit is one that has a balanced and even bearing surface over the entire scleral surface. The fitting lens is inserted and gentle pressure applied to the lens as the patient looks in all primary directions. Any marked areas of localized contact will necessitate an alteration of the trial scleral lens radius. Once the scleral radius has been established, the correct overall diameter is determined. With the patient looking nasally in the extreme gaze, any displacement of the lens means that the lens diameter is too large and a smaller lens diameter is needed. In 98% of all patients, a radius of 14 millimeters has been found to be used. The most common lens diameter for adults has been found to be 23 millimeters, whilst the majority of children are 20 millimeters and babies from 14 millimeters. All scleral lenses have a wide transition curve between the back optic radius and the scleral radius. The transition is normally 2 millimeters wide and has a curve of 4 millimeters flatter than the back optic radius. Gas-permeable lenses are becoming available with extremely high DK values, but it is believed that it will still be necessary to fenestrate scleral lenses because of the suction effect of a sealed scleral lens. 3 evenly spaced fenestrations at the limbal position are recommended. It is important that clean holes are drilled and that the edges are countersunk and well rounded and polished. These fenestrations are normally done in the laboratory in a standard position. The lens ordered from the laboratory includes the following parameters: scleral radius, overall lens diameter, optic radius, optic diameter, and the lens power. Apart from the keratoconic eye, it is generally possible to establish lens fit at the first visit, modify power and adjust lens clearance at the second visit, and give the patient lens handling instructions at the third. Adaptation to all-day wear can be achieved within 1 week. The fitting of gas-permeable scleral lenses to a keratoconic eye is somewhat more protracted, especially those with marked or decentered cones. The number of visits may vary from 6 to 15 visits to achieve an acceptable lens fit. However, this is considerably less time than the comparable fitting of a PMMA scleral lens. Up until June 1991, over 600 eyes had been fitted with gas-permeable scleral lenses at this Western Australian practice, with a success rate of at least 98%. All failures have been patients with advanced keratoconus. In some cases, the gas-permeable scleral lens provided a result that would not have been possible with any other type of contact lens. We should stress the importance and practicality for the practitioner being able to carry out lens modifications in his practice. The technique is not difficult and the equipment not expensive. With a little experience, the practitioner will be able to interpret the lens modifications required and to effect these accurately, especially necessary with a keratoconic cornea. It is not difficult to learn or do. The necessary modification equipment required consists of a set of grinding tools, preferably diamond coated as they maintain their curvatures, and their corresponding polishing tools, a vertical spindle and a dental type handpiece drill. A lens polishing machine would save time and ensure well polished lenses. The gas-permeable scleral lens is an advance for the contact lens practitioner and for his patient. For the practitioner, the lens is very much easier and quicker to fit. And for the patient, the lens is a more comfortable and acceptable lens to wear than the PMMA scleral lens. These factors suggest that the scleral lens will once again be readily available for those patients for whom it remains the lens of choice.
Well, keep in mind that that was 35 perhaps 40 years ago. But things have changed quite a bit since then. We've developed a reverse geometry back surface for the optical zone, keratoconic fitting sets for the back optic corneal zone. So it made it much, much quicker and much easier to fit. So, but that's, we have, as we'll come to shortly, today it's very different again. With these advanced technologies and these wonderful layers, we can virtually do anything. This was hard work, but it really wasn't rocket science. It's all back to basics, and it's really quite easy. It was easy to do. Thank you. Next. As I say, with the modern technology, it's really quite easy to fit a fenestrated lens. The main problem with the fenestration was the time taken to fit it. It wasn't difficult to do. It just took a little bit of time. In my practice, we used to do all the grinding away with a diamond tool to get the back fitting right. We didn't polish the lens during the fitting process. They had a local anaesthetic on the cornea. When we had the fit right, we took the lens, we usually sent it to the laboratory to polish. We polished it ourselves. They come back in. We had a nice fit. Make sure the refraction, over refraction was okay, was good, and we got them to start wearing the fenestrated lens. Next, please. Technology has changed. As I said earlier, the problem was time to get a really good fitting of the eye, of the lens on the eye. But today we have technology like eye print technology, where we can get a very precise fitting of the back of the eye. And once we've got, they have the good mold, there's wonderful computer technology to scan that, and we get a perfectly fitting lens. So all that's really needed from there with these new technologies is really to make sure you have a wide limbal clearance and a fenestration in the limbal area. And all that hard work that we had to do in the old days, in the past, is not difficult at all. Next, thank you. There's the Christine art print. You get a wonderful picture of the cornea and the sclera. No hard work required. In our day, before we had these wonderful layers, we had spherical corneas, spherical scleral areas, and we still got good results. But today we could get even better results. You get a wonderful picture and reproduction of the shape of the cornea and the sclera. Make sure that a nice wide limbal clearance, fenestration, and that's basically what you need to do. Next, thank you. Latitude scleral lens, same sort of process, but they scan the cornea. You get a precise fit of the eye. Easy. Then all you need to do is say good limbal clearance, fenestration, and you should get a lovely fitting lens. May have to make some compensations because the lenses do settle, but that should be very straightforward to work out and to do. Thank you. This is a latitude lens. I think Ed Boschnick lens. Very distorted eye, very distorted sclera, and you get a wonderfully fitting lens. This is a sealed lens, but as I say, good limbal clearance, good fenestration, nice fenestration in the right spot, and we've got it. Yes, next please. So using these technologies, plus the fenestration and a good wide limbal clearance, you just don't get a problem. It should be a very quick and precise fitting without any of the problems that we read about and are there with a sealed lens. Next, please. Okay. So these are the indications of scleral lens, the way we fit it, as large as possible. The larger the scleral fit, bearing surface on the sclera, the more balanced it is, and can lift it nicely off the cornea. They're the vaults that we suggest are needed. It's, with modern technology today, it will be so easy and so quick to get a fitting without any problems or any side effects. Thank you. Next. You've seen some of these pictures there. This is actually a Down syndrome little boy. There is touch there, but it's a stable lens, and you can get away with it. For example, with the babies, there's often almost a glove fit, but there is clearance at the limbus, and they can wear it quite nicely. We don't want an air bubble. This is a seal lens. We don't want a bubble in a seal lens. We do want a bubble at the limbal area. And an easy way of testing to see how the lens the final fit is just gently push the lens back onto the eye. The bubble will become smaller, and you'll see where the final fit's going to be. Next, thanks. This is one of the, we all see these patients now. The post-arcade, nice big bubble there. In my day, when we were fitting them, the lens was not a perfect fit on the sclera at all. And it's just as important to have that fenestration within the palpebral aperture. So we ended up putting three fenestrations equally spaced on the lens, so that always a fenestration would be located between the palpebral aperture. If modern technology, the ideal position is to have it just on the temporal side, just under the lid. That where I've got that little pointer there, I hope you can see it. That's the ideal place to put the fenestration. I know when Dallas was taking molds of eyes, he'd have a precise fit. He'd put a fenestration just within the palpebral aperture at the limbal area. Next, please.
Don, we had a quick question. So some people are wondering, you know, when a lens has a fenestration like that and there's bubbles, do the bubbles tend to distort vision?
Yeah, well, then those fits are not ideal. The bubbles should be much smaller, but if you just press, as I said earlier, push the lens back onto the eye, the bubble will become smaller, and you'll see where the final fitting will be when the lens settles. But it's just important to have I think the one on the patient's right is probably better than the one on the left. We've still got that bubble. When the patient looks around, that'll go around the limbal area. But no, did I answer your question? What was the question again?
Yeah, I would add something. The fenestration should be positioned so the whole of the fenestration hole should be positioned so the final position of the air bubble is partly in the cornea and partly in the limbus, in the limbal area. And this is very important to do that, is to assess limbal vault, which need to be at least 75, 100 micron, because good limbal clearance allows an air bubble to circulate around the limbus, ensuring a constant oxygen supply to the cornea. Yeah. And this limbal clearance will assure that the bubble will stay within the limbal area and will not go to the limbal to the corneal area.
If we have too much of the bubble over the cornea, you will get discoloration. So it needs to fit it, as Daddi explained much clearer than I did. As long as that bubble's within the limbal area, it will work well. If it's too far over the cornea, you will get discoloration. It won't be comfortable.
And just one other thing, the holes should be stabilized also. The early manufacturing process did not have the ability to make a stable lens on the eye, so to keep the holes in the correct position within the palpebral aperture. So to ensure that the holes are always in desired position at all times, the three holes should be placed at 12, 4, and 8 o'clock, so they can form a triangle shape. And the hole diameter should be about 0.51 millimeter. And they should be properly rounded, also polished to avoid debris formation and discomfort.
Yeah. I have read in some of the journals or and even books, one of the problems with the fenestration is you get debris in the fenestration. Well, that really, if that does happen, when the rounding of the fenestration holes is not good, that needs to be rounded properly. How do you clean the holes? Well, using the greatest technology we had, we just got the patients to get a soft toothbrush, moisten it, and just gently push it onto the back surface of the lens. The bristles will go through, and then very scientifically, we got the patient to blow through it to make sure they were clean. We never had a problem. If we did have a problem, the fenestration was not a good fenestration, and the edges needed to be well rounded.
Mm-hmm. Yes, and just as Don said before, that when you place the lens on the eye, you may have a bubble in the corneal area and also in the pupil area, but just push the lens onto the eye and the bubble will reduce in size, and you can see the final size and the position of the bubble.
Daddi, I have a quick question about that. Do you instruct the patient to do the same thing? You keep saying push it on. It seems like that's going to be something that they need to know for when they're putting it on their own.
No,
Okay.
that's sorry, Daddi. That's when you're fitting the lens. You can estimate quite accurately the final shape and the size of the bubble. The patient just puts the lens in. They don't touch it except maintain it and keep it clean.
Okay. On that same note, Dr. Aitzembamo from San Antonio here in the US is asking about if the patient themselves has to worry about orienting the lens to get the holes into the proper place. You're shaking your head no.
Now the lens will position by its own on the ocular surface because it's stabilized. The stabilization of the lens may be made with toric back surface toricity or with the new technology like iPrint or latitude scale lenses that stabilize on the eye immediately. So once stabilized, they will be on this position as a triangle.
Yeah, it really doesn't matter. You just put the lens in and there'll always be a fenestration within the palpebral aperture.
So
Great.
another question.
I'm going to ask just one more question because I've got you here before you start this next part. We've gotten a couple questions about the use of fenestrated lenses for dry eyes. So can either of you speak to your experience? Do they still work as well as a sealed lens for dry eye? And do you have any comments?
I found they work well for any sort of an eye, really. There's always moisture in the eye, and the protection of the lens. There's always some lacrimal tear between the cornea and the back of the surface of the lens. So they work very well for those sort of eyes.
Yeah, definitely, yes, I agree, because when you fit the lens, it's empty, but once in the eye, it will be filled with the tear exchange, with the tears, and it will be a continuous tear exchange through the holes. So the eye will be protected with the fluid reservoir, which is not anymore a fluid, which is a tear reservoir, and only in the air bubble you may have an empty area. However, the bubble will be floating all over the limbus, so there will be no any area of desiccation. And the good thing of the fenestrated scleral lenses in dry eye is that they have a large diameter, so they protect much more area exposed of the ocular surface. So definitely, yes.
And the other nice thing with the fenestration is that as the patient blinks, even with a dry eye, it's like a little pumping action, and you do get an interchange of tears through the fenestration. So, and what's more healthy for the eye than having a lacrimal tear rather than an artificial substance?
Yeah, and dry eye patients, we know that they are more predisposed to have debris in the tear reservoir, and the hole will help in renewing the fresh tears inside the lens. So this is also another advantage of fenestrated scleral lenses in dry eye patients.
And just another nice thing, you saw inserting the lens on the eye. No filling the lens up with solution. Very easy to slip it in and very easy to take it out. So, so even with a pediatric patient, that little baby there, you know, they all put on a performance, but she just smiled afterwards. Getting out is also not so difficult. It's just like taking out a corneal lens, but except that it's larger.
Yeah, fenestrated scleral lens application removal is very, very easy because, as Donald just said, that they don't require the filling of lens solution, and as we saw in the video, it's very easy to put it in elderly and pediatric patients. Also, lens removal does not necessitate any suction device. So with fenestrated scleral lenses, you don't need any device, neither for application or for removal. And if a plunger is required for any reason, such in case of dexterity issues, to facilitate lens removal, the plunger should be placed in the center of the lens and removed in this way. And that is because the lens has no suction. And Don told me that if you put the plunger near the edge, as we usually do, it will make the removal more difficult in fenestrated scleral lenses.
You know, in my practice, I never ever gave a patient a suction cup. If they couldn't handle the lens themselves, they had to come back and come back till they could do it properly. What happens if they're out and they need to take it out for a reason and they haven't got a plunger? So we always carry our hands around with us, so it's easy to do. Well, this is you saw that slide of that little old lady. You saw it in the video. In those days, we didn't have intraocular lenses. She had a phakia. And look at those poor old hands. She could get the lens in and out, so she was really self-sufficient. That's no filling it with solution, no bending over, having fancy gadgets with you. Just wash it, wet it with a wetting solution, slip it in, and the patient's off. Next one. So these are the problems we read about in books and in journals. That these are problems that can occur and obviously do occur because they're written up. Lens fogging is unique to a seal lens. Lens deposits, limbal touch, neovascularization, handling is easy, and it just is safer, I think, not to interfere with nature as much as we can. We're putting a foreign body in the eye. Isn't it better that the normal lacrimal tears are still there, doing their work without having some foreign solution included? Next one, thank you. So that's the question, I guess. Can we do even better scleral lens for our patients? We are getting great results. Patients worldwide are so grateful that they can see again and are comfortable, but can we do better? Thank you, next. So the question I put to you all, is a fenestrated scleral lens a healthier long-term option for our patients? I've been fitting scleral lenses for a long, long time, working in the early 60s with Dallas. I knew Dallas, Beer, Rubin. I worked with these people. They were all fitting fenestrated PMA scleral lenses. And I've been fitting scleral lenses now since that time, even before. And I've seen patients in the long term wearing lenses, coming back routinely for polish or an upgrade, and the corneas are very healthy. So I guess that's the question I pose. Is a fenestrated scleral lens a healthy long-term option for our patients? Thank you, next.
Yeah, we both, Don and I, both agree that scleral lenses of the future will be more likely lenses that allow continuous circulation and exchange of tears, so flow of fresh tears to the corneas. So we think that there is a potential return to the earlier modern scleral lens made with gas permeable fenestrated scleral lenses, and including one or more fenestrations. So we have done. Thank you for your attention and for attending.
Any queries? Daddi is ready to answer all questions.
Yeah, we have quite a few questions for you. Some of them have been answered. So let's see. So would the edge profile, or I guess that landing zone, haptic, whatever you want to call it, be the same for a regular scleral lens? We understand this design fits closer to the cornea and elevated more on the limbus. So is it reverse geometry? What's the theory behind 3 holes? I guess that's a few questions.
Well, interestingly, the landing zone is a new description that came up with sealed lenses, sealed scleral lenses. In a fenestrated lens, we didn't talk about a landing zone because we're well clear of the limbus. It's not a tight fitting lens because a loose fitting lens is even ideal. So we didn't worry about. We didn't talk about landing zones. So as long as you've got a nice wide limbal clearance, it's nowhere the landing, if I may say, is nowhere near the cornea. And it's a loose fitting lens. You've got a fenestration there, so there's no suction. It just sits on the cornea, sits on the limbal area, clears the cornea, nice limbal clearance, and it works. Did I answer the question? I'm sorry. Did I miss something?
Yeah, I think so. I think so.
I think the 3 holes, what is the theory around the 3 holes? I think that the 3 holes are important because they allow the air bubble to move around the limbus, because only if you put only 1 hole, you will see that the air bubble will stay there. 2 holes, the bubble will be in their area. 3 holes will allow the air bubble to move, so there is no desiccation in the corneal area when you remove the lens.
And so do you guys know of any peer-reviewed papers that have looked at whether or not the fenestrated lens is healthier than the sealed lens?
No, there is no peer review. The only peer review paper on modern fenestrated scleral lenses and gas permeable lenses are our paper. And we invited, in our paper, we invited everyone to study the lens suction, the tear exchange, and also all the issue that may scleral lens manage, because all the topics we talked about, all these problems we talked about that can be managed with scleral lenses are based on several years of clinical practice, clinical experience of Don Ezekiel. I have very, very little experience with fenestrated scleral lenses. So everything was based on his clinical experience on several years. But we definitely need some peer review studies.
Now we must keep in mind that we're putting a foreign body in the eye, and the less we can disturb or interfere with nature, the healthier the result's going to be. So we put a lens in which is going to clear the cornea, at the limbus, which is the most important area, and a nice loose fitting lens on the sclera, and using the tear to lubricate the cornea. I think that's a safer option, but I'm a little bit biased.
Well, I can say something as a conclusion taken from other studies, because we saw that the preserved saline, non-preserved saline, when we put it in the scleral lens, when we remove the lens, we will see epithelial bugging. And also we saw some issues with the breeze. when switching to, there's no studies on there. However, when switching to neutrophil solutions, the problem of debris reduced. So the problem with scleral lenses is not only about the oxygen or the hypoxic issues, but also about the kind and the quality of solution we are putting in the lens. Fenestrated scleral lenses allow tear exchange, so we have fresh oxygen, fresh tears coming to the cornea. Probably that will help in having a safer cornea than sealed scleral lenses.
Thank you. So in terms of the diameter, are fenestrated scleral lens limited to large sclerals, and or what is the smallest diameter that a fenestrated lens should be made in?
Well, on the basis that the larger the fitting, the more balance you've got on the sclera, the more you can stabilize the lens and just clear the cornea perfectly. So my teachings were that the larger the better, and you get a healthier result. So the diameters, as we've shown, the largest, most common was 23 millimeters, but some we've even gone 24, 25 millimeters. For the young adult, maybe 20, but for the babies, 14, 16. This is how I actually started getting involved with gas perm materials, because I was, there were some doctors at the Children's Hospital that had trained in London and knew the results, the wonderful results I was getting with scleral lenses. And I was getting a call almost once a week. And I'd go to theatre, anaesthetize, the patient was anaesthetised while the doctors did what they had to do. And then I'd take an impression of an eye. And that was hard work. It was hard for the patient. It was hard for the parents. It was very hard on me. So I thought there's got to be an easier way. So at the end result was we had gas perm sclerals, fenestrated lenses of two diameters, a 14 and a 16, depending on the baby. The larger the better. And we had a power of about plus 30. And we just insert the lens to make sure the parents knew how to handle the lens, and we could modify the power, because, you know, when they're little, their focal length is very close. So 30 was about right. And then as they got older, we could refine the power with the same lens. So I don't know if I answered your question, but the larger the better.
Great. I think that answers it. Okay, just a couple of more here. So is a fenestrated lens expected to move more than a sealed lens? And if so, what is the acceptable amount of movement?
Well, the lens will move if one looks to the extreme areas, but that really doesn't matter. In fact, it's better to have a loose fitting lens than it's not a sealed lens in any form at all. I don't know if I've answered your question, but the larger, the more balance on the cornea, the more comfortable the patient will be.
Yeah, I think that answers it. So they move some.
Keep in mind that we've got a foreign body in the eye, and we've got to, nature is wonderful. We don't want to interfere with nature unless we have to. So keep it as natural and normal as you can. So we're putting a foreign body in the eye and using the eye's defense mechanism and the tears to look after the eye. We don't want to create a problem for ourselves. It may be easier to fit a sealed lens, but I think with modern technology, with the scanning and the impression, it's really all the hard work's done. It's all the hard work's done. All that they need to do is to modify the limbal area and fenestrate.
I love it.
Yeah,
I think we would all be wise to, let nature be nature, I think is an important lesson of our lifetimes. So let's see, we've got just a couple more. So how about Sjogren's syndrome? Have you used this for patients with Sjogren's dry eye?
Sorry, with children's dry eye?
With Sjogren's. Like the pathological, probably with more older patients then.
No, we use the same principles for everybody. And with the one good thing with the gas perm materials is that if, in fact, you teach the parents how to insert and take the lens out, parents are the problem. They're the most important parameter in the whole exercise. But if they, and I say to them, great, you know how to handle it, come back in a week, but if you can't handle it, if you're having a problem, leave it in. Don't upset the child and upset yourself. Come back tomorrow morning. We'll go through the whole routine again. And if they're okay, they take it out. If they're not okay, come back tomorrow. We'll do it again.
Okay, thanks so much. In the interest of time, I'm just going to ask you one more question here, and it's got a little bit of a two-parted one, but it's pretty simple and straightforward. So, which material do you typically use for these lenses, and do they require frequent polishing for fenestrations and protein deposits and that sort of thing?
I think use the best high decay material you can have. We want to give it the best. It's a foreign body, but give it the most help you can give it. So I think, I don't know, there may be better gas perm materials available now, but I'd use a high decay, one that's stable and doesn't bend, so you can make it nice and thin. No, not a problem. I don't know if I answered the question again, but any material that works well, high decay will work well.
Yeah, I don't think there is a specific material to make a fenestrated scleral lens. All the materials available for sealed scleral lenses are good for fenestrations.
All right, well, thank you so much, you guys, and thank you for hanging out with us tonight and asking good questions. Again, we have some, really exciting talks coming up as well, and the dates are there. Check your emails for that post-webinar email that will be sent out. And again, if you need CE for this talk, make sure you send us your OE tracker number and let us know if you need a post-CE quiz. Just respond to that email. Thank you again, Dr. Ezekiel and Dr. Fadel. Great talk.
Thank you. Thank you for this opportunity again. Thank you, everyone.
Bye.
Thank you.